Good morning, everybody. Uh, Thank you for joining me here. We are trying to talk about how AI, automation, and workforce come together, kind of to support patient access. And and what we've realized is that you have had multiple conversations in this conference that talk about each of these individual concepts of how to kind of improve your workforce, how to apply AI, or how to apply automation. I want to talk about how we bring all three together, particularly in the patient access space. What are we hoping to cover? We are hoping to cover what the core enterprise challenges are that we see with applying within the patient access space, and what a technology-driven approach might look like, and what we can see as financial benefits associated to something like this. So let's kind of dive right into it. What are the key challenges we are seeing, right? And some of you can reflect on it. Uh, we're seeing patient access teams having to do more with less, whether that is more work with less people or more communication. So if you look at everything that has increased on the patient access teams, patient communication has increased. The number of touch points that they have to interact with patients have increased over this period. Patient access teams now actually have the responsibility for kind of the financial aspects of the patient. In the past, you could kind of check in the patient, greet the patient, and be on with it. But now you have to make sure that you collect the right amount at the point of service. The number of things that require prior authorization have just kept going up, which means you don't know whether you can render service unless you know whether the payer requires authorization or not, which usually means you're now having to have that additional communication with the patient about what needs to happen. And I talk about it as kind of two distinct halves, right? The patient access teams have to, at one point, turn on empathy with the patient and at the same time get frustrated by the payer in the same hour, right? And the way you think about that is, at one point you're trying to comfort Susie that she's going to get her MRI done because she's worried now that she's got some major ailment. At the same time, she's on a phone call with United trying to figure out how to get Susie in through the door as quickly as possible. And finding that you need to submit 20 documents before you actually can see Susie, right? And as these teams get bigger, it becomes even more difficult. What we've seen is it's more challenging to actually manage larger teams as you get, if you have 4 or 5 people in the front office, it works, but now you start to have larger and larger teams. How do you organize them? How do you make sure that they're most productive? How do you make sure they don't get burnt out? And those are challenges that we're seeing because the workflow is not a uniform workflow. If we go to Amazon, it's so much easier to kind of shop for a thing, click buy and get it at your doorstep than kind of getting a patient through the door. The number of stop starts that you have to have, call me back later because I don't have authorization. We'll schedule these 7 days out. We'll find a new appointment if one exists earlier. So the number of stop starts in the process are significantly higher. So, and the other thing is to interact with the payers, you actually need a fair amount of expertise because every payer is not equal, doesn't work the same way. So you now have people who have to have expertise to empathize with the patient, but also have expertise to understand what the payers need with respect to the activity. And the more we interact with our customers and partners, what we're realizing is that it's difficult to find these people now. And it's easier said than done. We have had some rural hospitals who are customers said that I think they're losing people to Target or Hobby Lobby or something else. And people are, these folks are saying, why does it matter? Why should I work here? It's such a stressful environment. So the question is, how do you change that environment and how do you assist them with technology? And I use the word assist, not replace, right? Because There's a lot of conversation about how somehow AI is going to make all of this better. And we believe in the potential of AI, but let's talk about how it amplifies our capability at this point rather than replaces our capability. And I'll bring up a few things that go into it, right? You do want machine intelligence or AI as we talk about, but you want it to be applied to things that provide kind of value in prescriptive sense to the human to do the work. You want it to work with your EMR because you've made a big investment in your EMR, so you don't want to be out of the EMR and in the EMR and back out of the EMR and have somebody having to copy information over. I've seen many times patient access teams say, wait a minute, if I have to use a separate tool, I might as well put it in the payers portal. Why do I spend the time doing this, right? So you want to make it work as seamlessly in the workflow. The other thing is you want to be able to orchestrate the workflow, and I'll talk about that a little bit because essentially we talk about automation a lot. We hear a lot of conversation about automation, but can you orchestrate it with the machine and the human? Because if the human tasks cannot be orchestrated, then now you have a discontinuous set of tasks. And it becomes more challenging to kind of take data out to kind of create automation and get the data back in than actually do the automation. So how do you talk about that orchestration is the other component that we want to talk about. And then we'll also talk about digital agents, because essentially certain of these tasks can actually be done by digital agents, and we believe that you can actually get a lot of value in applying automation to it. But the question is, how do you do that kind of in a more cohesive fashion? So let's talk about machine intelligence first, right? Where can the machine be intelligent? And you've heard a lot of sessions here today about AI and related growth. And in the last year or two, AI has really started to kind of make a very prominent kind of impact on the kind of use cases you can do. So let's talk about a few of them. You think about the life cycle of the patient access. The first thing the person is trying to figure out is, does this patient need to pay out of pocket, and what is their propensity to pay? Can I engage them financially or should I not engage them financially? The next thing you're trying to determine is, does this require authorization? Right? And AI can actually kind of look through a lot of data and very quickly tell you if something requires authorization or not. The next thing you want to understand is, if you need authorization, you want to be able to submit the request for authorization. Do you have all the clinicals? Did the physician document everything? If you don't, you need to actually get the physician to document all the data before you submit it. And that AI is really good at kind of now looking through clinical documents and saying, yeah, this meets guidelines or this does not meet guidelines. And once you are able to submit it, the next immediate question is, am I going to get approval now, or am I going to get approval 5 days out or 7 days out or 14 days out? And machine learning is really good at looking at data at scale to kind of understand what the payer patterns look like. So these are some very kind of quick use cases how machine learning can actually help, or machine intelligence can help within the patient access lifecycle to amplify the human ability to schedule that patient as quickly as possible. Right? And the good thing about AI, we've talked about a lot of AI being predictive, as in you can predict something can happen or not. But with the advances that we are seeing, AI can become more prescriptive. They can actually tell you to do something or not to do something, right? Schedule this patient, or schedule this patient 3 days out. And you have all the documents, or no, your physician hasn't documented conservative treatment, so you may want to make sure that it's there before you submit it for prior auth. Otherwise, you may get a denial or you may get a peer review. These are things that you can actually today have AI to do it, rather than rely on having your front office staff to sift through this data and figure this out, right? That's where I think there is a immediate value of applying machine intelligence in this process. What is the other big thing? The other big thing is workflow orchestration, right? If you have a large enough team, how do you organize work? I've met many teams, they say, oh, we do patients A through F, right, G through H. The problem with the mechanics of that is that essentially, if you have 10 different patients, but they have 5 different insurances, now that front office person has to understand how to deal with 5 different insurances. So is it better to organize that way, or better to organize in a different way? And you apply machine learning to actually kind of understand whether the right approach of organizing work and productivity. Because at the end of the day, you want to be able to measure and provide productivity. The second thing is auto allocation of work, right? Can you allocate work without somebody going and cherry picking from a big queue? Can you give them the work that they're really good at? If I found that Susie's really good at doing United because she turns around United much faster. She's built an experience around doing. Can I give more of United to her, even though the patients don't fit within the A through F within her world? Right? That's kind of an auto allocation mechanism that you want to be able to have. And the next thing is you want to be able to integrate automation and automated agents with what I call humans. So now let's think about the examples I gave around machine intelligence. You can auto-determine using machine if author is required. You want to initiate, you need a human in many cases to initiate because clinicals have to be reviewed. And then if you follow up, automation can do the follow-up. Now, if you can orchestrate these things where the first piece of work goes into a machine queue to determine if author is required. If author is not required, it doesn't ever see a human queue. If it requires authorization and clinicals need to be submitted because machine intelligence tells us clinicals may be required for this, you put it into Susie's queue. So Susie only sees the patient which has a complex scenario where clinicals have to be submitted. Now Susie submits the clinicals and initiates the authorization, and pair says follow up later, and I'll tell you what the auth looks like. You can take it immediately and put it into a machine follow up queue, and in that case, Susie doesn't have to worry about that patient anymore because now the machine would follow up on behalf of Susie. So you can see how orchestration can be very powerful in bringing kind of the machine agents and the human agents together. And it's going to be very critical if we are going to be successful deploying automation. Because if automation sits on the side or doesn't completely integrate with the workflow, it'll actually add more to the effort than actually reduce the effort. The other big thing is kind of being seamless within the EMR, right? You've made a big investment in whether it's Epic or Oracle Health. Your primary scheduling lifecycle lives in it, but you can't do all the work queue structures that you want to do. You can't orchestrate the automation there. How can you seamlessly integrate with that platform? How can you be connected in a way that you actually get the data in, you can process it, send it out, and come back in, and the scheduler never knows that it went somewhere, got processed in some shape, and came back to you. You want it to be that seamless, because if the scheduler or the front office staff has to go to another tool, now you have to teach them another tool, and you don't want to teach them another tool. The mechanics of the process has to be that it can actually do it separately. But at the same time, there is also a challenge. You're trying to scale up, let's assume vendor staff, or you're trying to scale up temporary staff to do this work. Do you want to give them access to all of your Epic just to have the work queues? Maybe not. Maybe you give them access to the patient access tool to do the work queues. As long as the data gets back in Epic, you now no longer have to worry about your temporary staff having access to all your patient health information, right? Those are some of the aspects that a EMR integration kind of brings into it. And last but not least, we want to talk about automation agents, right? A lot of the tasks that are there when you think about patient access, whether that's eligibility or coming up with an estimate or actually performing prior authorization, you're actually going to a payer or a payer portal or directly connecting with a payer to get the data. Most of them can be automated. Now, the unfortunate part is they're not fully automatable in the sense that certain parts may still need human interventions. So you want automation that can actually work seamlessly with the human, with your agent. Because if the machine actually just sits on the side and does it differently, it's going to have a challenge. So you want digital agents that can actually work unattended, which means they actually don't need any human intervention, right? So if you've done a prior auth request and you have a case reference number and you need to just follow up on that case, you don't need a human to do that. You can just let the machine do it whenever it does it. But there are certain areas where you need what is referred to as a human in the loop automation. And a scenario like that is that you're actually trying to do an authorization initiation. And when you try to do that, you find that you actually have to answer clinical questions. And when you have to answer those clinical questions, you need a person with clinical expertise. So the automation can do a lot of the work, but then it says, wait a minute, I can't answer these clinical questions yet. I need a person, I'm going to prompt a person to do that work. So that's kind of human in the loop automation. So you want automation agents that can actually support both ends of it as you're doing this. More importantly, these automation agents have to be continuous learning and adaptable, right? As the payers change their behavior and approach to doing this, you want the ability to have that data be understood and the machine to learn faster and adapt to the process, rather than if the payer changes behavior, now your process is broken, now you need to find the people. The challenge you have is the moment you introduce digital agents into your life cycle is that you've made those humans do something else. They're not going to come back. So if those digital agents stop working for you, now you are stuck because you need to find people to do the same work. So you essentially want digital agents that can learn and adapt through the process. So that's kind of the core elements of it, right? So I'll kind of quickly kind of recap like how I think about it, right? You want any solution that can help you with patient access to seamlessly fit within your EMR. It has intelligence to actually perform some of the tasks that you're needing. It has automation agents that support doing some of these tasks. But when work needs to be done by the human, it knows how to intelligently and seamlessly orchestrate it with the human. So the people who are doing the work are only prompted to do the work when they have to, rather than sit on queues the whole day trying to figure out how to get this work done. It reduces your front office staff from having to sit and deal with a lot of this, the payer noise and payer frustration that they have to deal with. And they allow them to be more productive from a value perspective rather than just an output perspective. I think of it as more outcome productive than output productive, right? Those are some, I would say, big areas such a solution can bring, right? What are we going for? Of course, we're always going for cost savings. No questions. We were all trying to do more with less. So cost savings are important. But at the same time, the way we think about patient access is that it actually is a revenue enhancer as much as a cost reduction process. Because from a revenue perspective, if you can actually get a patient scheduled faster because you understand what their needs are and you know what the payer requirements are, then you actually have more patients coming through the door. The day you say somebody needs to be 7 days out, Susie, who was trying to get an MRI, who doesn't want to wait 7 days, they're going to start shopping around to find who else can get an MRI faster, right? And then the other big thing is it reduces kind of revenue risk downstreams, because if you look at a lot of what happens downstream in revenue cycle with respect to AR is that you have coordination of benefit or eligibility or prior auth related denials. That's just because the front office just didn't have enough time to do it. So now you reduce the burden of the risk at the back end. But more importantly, I think you will have a more productive workforce, a workforce that kind of feels like they're in healthcare because they're working with patients rather than just being on phone calls with BCBS on 30 minutes. And because many people come to healthcare because they want to empathize with patients and work with people. And hopefully a solution like this allows them to do that and be more productive and happy in their work. I'll pause there. Any questions? Happy to take them. Thank you for your time. Appreciate it.